Welcome to our comprehensive guide on furcation involvement and its management. Furcation involvement is a common dental condition affecting multi-rooted teeth where the bifurcations and trifurcations become invaded by disease. Understanding the anatomy, etiology, classification, clinical features, diagnosis, prognosis, and treatment options is essential for effective management. In this video, we'll break down each aspect step by step, starting with the basics and moving through advanced procedures. Whether you're a dental professional or a student, this resource will help clarify the complexities of furcation involvement and provide actionable insights for clinical practice. Let's begin by exploring what furcation involvement actually means and why it matters in periodontal health. Furcation involvement refers to the pathological resorption of bone within the furcation area of multi-rooted teeth. According to the American Academy of Periodontology, this condition occurs when disease processes invade the bifurcations or trifurcations, leading to bone loss. The furcation is the space between individual root cones, and its involvement can significantly impact tooth stability and periodontal health. Recognizing furcation involvement early is crucial, as it often signals advanced periodontal disease and can complicate treatment. In the next scene, we'll delve into the detailed anatomy of the furcation region to better understand how these changes occur. To understand furcation involvement, it's important to grasp the anatomy of the furcation region. The root complex is the portion of a tooth located below the cemento-enamel junction, CEJ, and is divided into the root trunk and root cones. The root trunk is the undivided region between the CEJ and the separation line of the roots, while the root cones are the divided regions that make up the furcation area. The furcation itself is the space between these cones, and the furcation formix is the roof of this area. Divergence refers to the distance between two roots, which increases apically. The coefficient of separation describes the length of the root cones relative to the root complex. These anatomical features influence how disease affects the furcation and the challenges faced during treatment. Let's clarify some key terminology related to furcation anatomy. The root trunk is the undivided region of the root, while root cones are found within the divided region. The furcation is the area between individual root cones, and the furcation formix is the roof of this space. Divergence describes the increasing distance between roots as you move apically. The coefficient of separation measures the length of root cones in relation to the root complex. Understanding these terms is essential for diagnosing and managing furcation involvement, as each anatomical feature can influence disease progression and treatment outcomes. The primary etiologic factor in furcation involvement is bacterial plaque and chronic inflammation of periodontal tissues. Long-standing inflammation leads to attachment loss in the furcation area, which is influenced by anatomical considerations such as root trunk length, root separation, and the surface characteristics just above the root separation. The roof of the furcation, often concave and containing ridges, can make access for instrumentation difficult. These anatomical challenges, combined with the presence of bacterial plaque, set the stage for furcation involvement and complicate both diagnosis and treatment. Several anatomical factors affect the extent of attachment loss in furcation defects. Root trunk length determines how early the furcation becomes involved. Shorter trunks are affected sooner, while longer trunks are harder to instrument. The degree of root separation improves access and facilitates instrumentation. Concavities on the inner surfaces of exposed roots increase the attachment area but make plaque removal challenging. Cervical enamel projections, present in about 15% of molars, favor plaque accumulation and must be removed for effective scaling. The anatomy of the furcation, including bifurcation ridges and accessory canals, can complicate treatment and healing. Cervical enamel projections are anatomical variations found in approximately 15% of molars. These projections extend from the cemento-enamel junction toward the furcation entrance and are classified into 3 grades. Grade 1 projections extend toward the furcation entrance. Grade 2 approach but do not enter the furcation, and Grade 3 extend horizontally into the furcation. These projections favor plaque accumulation and must be removed to facilitate scaling and route planning. Their presence can complicate furcation treatment and influence disease progression. Accessory pulpal canals are small channels that connect the pulp chamber to the furcation area. When the pulp becomes infected through these canals, endoperio communication can occur, leading to destruction of the interradicular periodontium or interfering with healing after periodontal or endodontic procedures. The presence of accessory canals complicates furcation treatment and can affect the prognosis of the involved tooth. Recognizing and managing these canals is important for successful therapy. The shape of bone in the exposed furcation area has both horizontal and vertical components. The horizontal component determines the grade of involvement, while the vertical component often creates a depression similar to a crater in the interdental area. Vertical or angular bone loss can occur toward one of the roots, and these defects may have 1, 2, or 3 osseous walls or be funnel-shaped around a root. Understanding bone morphology is essential for classifying furcation involvement and planning appropriate treatment. The presence of sufficient attached keratinized gingival tissue and adequate vestibular depth is important for managing the furcation area. These factors facilitate gingival management and improve access for instrumentation. Without adequate gingival tissue, treatment may be more challenging and healing less predictable. Ensuring proper gingival health is a key step in the overall management of furcation involvement. Glickman's classification 1953 is widely used to categorize furcation involvement based on clinical and radiographic findings. Grade 1 represents an incipient or early lesion with slight bone loss and no radiographic changes. Grade 2 involves partial bone destruction, forming a cul-de-sac with possible radiographic evidence. Grade 3 is characterized by complete loss of interradicular bone, forming a thorough and thorough tunnel, often visible as a radiolucent area on radiographs. Grade 4 also has complete bone loss, but the furcation opening is clinically visible due to gingival recession. This classification helps guide treatment decisions. Tarnow and Fletcher, 1984, introduced a classification based on the vertical component of bone loss in the furcation area. Subgroup A involves vertical destruction up to 1/3 of the interradicular height, 0 to 3 millimeters. Subgroup B extends up to 2/3, 4 to 7 millimeters, and subgroup C involves destruction beyond the apical third, 7 millimeters or more. This classification provides additional detail for assessing the severity of furcation involvement and planning treatment strategies. Hump et al. 1975 classified furcation involvement based on the horizontal component of bone loss. Degree 1 is defined as horizontal bone loss of less than 3 millimeters, Degree 2 as more than 3 millimeters, and Degree 3 as a thorough horizontal lesion. This system helps clinicians evaluate the extent of bone loss and choose appropriate treatment modalities. Several other classification systems exist for furcation involvement. Goldman, 1958, uses grades 1 to 3, with grade 1 as incipient, grade 2 as cul-de-sac, and grade 3 as thorough. Ramfjord and Ash, 1979, classify involvement as Class 1 less than 2 mm tissue destruction, Class 2 more than 2 mm but not thorough, and Class 3 thorough. Fedde, 1985, offers a similar grading system, with further subdivisions for grade 2 based on interradicular bone loss. These classifications help tailor treatment to the specific severity and characteristics of each case. Clinically, the mandibular first molars are the most common sites for furcation involvement, while maxillary premolars are the least affected. The furcation may be visible or covered by the pocket wall and is often associated with suprabony and infrabony pockets. Periodontal abscesses, root caries, and tooth mobility are common findings. Recognizing these features is important for early diagnosis and effective management. Microscopically, furcation involvement begins with the rootward extension of the periodontal pocket. Early stages show widening of the periodontal space, with cellular and inflammatory fluid exudation, followed by epithelial proliferation into the furcation area. Inflammation extends into the bone, causing resorption and reduction in bone height. Bone-destructive patterns may produce horizontal loss or angular osseous defects associated with infrabony pockets. Plaque, calculus, and bacterial debris occupy the denuded furcation space, further complicating healing. Diagnosis of furcation involvement relies on careful probing using a curved, graduated periodontal probe, such as the neighbor's probe, an explorer, or a small curette. In maxillary molars, the mesial furcation entrance is closer to the palatal surface, so probing should be done from the palatal aspect. The distal furcation is midway between buccal and palatal surfaces and can be probed from either side. The distal maxillary furcation is most frequently involved. Accurate probing is essential for identifying the extent and location of furcation involvement. Radiographs are used to confirm findings made during probing of furcation involvement. Proper angulation and divergent roots can reveal lesions as radiolucent areas between the roots. However, radiographs may not always detect early or partial involvement, so clinical probing remains the primary diagnostic tool. Combining both methods ensures accurate diagnosis and guides treatment planning. Furcation involvement is more likely in multi-rooted teeth, such as maxillary first premolars and molars, as well as mandibular molars. Maxillary first premolars often show root fusion and apically located furcation areas, leading to poor prognosis. Maxillary molars have 3 roots and multiple furcation openings, making plaque control difficult and prognosis unfavorable. Mandibular molars have 2 roots, usually divergent, with buccolingual furcation openings, resulting in a better prognosis. Understanding these differences helps predict treatment outcomes. Several factors must be considered when deciding on a mode of therapy for furcation involvement. These include the degree of involvement, crown-root ratio, length of roots, degree of root separation, strategic value of the tooth, root anatomy, residual tooth mobility, endodontic therapy and complications, ability to eliminate the defect, and the periodontal condition of adjacent teeth. Assessing these factors ensures that the chosen treatment is appropriate and effective for each individual case. Traditional treatment procedures aim to maintain periodontal health without attempting to regenerate lost tissue. The goal is to prevent further disease progression and provide an environment conducive to plaque control. For Grade 1 involvement, initial preparation includes scaling and root planning, curettage or gingivectomy to expose the furcation area, and odontoblasty to reshape facial grooves. For Grade 2, osteoplasty with limited ostectomy and odontoplasty may be helpful. Severe Grade 2 to 4 cases may require root resection, hemisection, bicuspidization, or tunnel preparation, though the latter is rarely performed due to increased risk of root caries. Root resection involves the surgical removal of all or part of a root, either before or after endodontic treatment. Hemisection is the surgical removal of a root with its associated crown portion, commonly performed in lower molars. Root separation or bicuspidization involves sectioning the root complex and maintaining all roots. These procedures are indicated for severe bone loss affecting one or more roots, Class 2 or 3 furcation involvement, and severe recession or dehiscence. Contraindications include systemic diseases, poor oral hygiene, fused roots, and unfavorable tissue architecture. The procedure for root resection, hemisection, or root separation begins with local anesthesia and the release of a full-thickness mucoperiosteal flap. After debridement, the root with advanced bone loss is resected using an oblique or horizontal incision. The root is elevated and removed, and odontoblasty may be performed to correct furcation deformities. If adjacent teeth have bony defects, resective or regenerative procedures are carried out. The flap is then approximated and sutured to maintain position. Proper technique is essential for minimizing post-operative pain and ensuring successful healing. Surgical procedures such as root resection, hemisection, and root separation are indicated for severe bone loss affecting one or more roots that cannot be treated with regenerative procedures. They are also used for Class 2 or 3 furcation involvement and severe recession or dehiscence of a root. These interventions are reserved for cases where traditional therapy is insufficient and the strategic value of the tooth warrants preservation. Contraindications for surgical procedures include systemic diseases, poor oral hygiene, fused roots, unfavorable tissue architecture, and roots that are endodontically untreatable. It's important to assess the patient's overall health and dental status before proceeding with surgery. In cases where contraindications exist, alternative treatment options should be considered to avoid complications and ensure optimal outcomes. Reconstructive and regenerative treatment procedures aim to restore lost periodontal tissue and improve tooth stability. For Grade 1 furcation involvement, traditional treatment is usually sufficient. For Grade 2, various regenerative techniques are available, including autogenous bone grafting, allografts, alloplasts, citric acid root conditioning, and guided tissue regeneration. Combination techniques may also be used. Success rates for Grade 3 and 4 furcation involvements are limited, making early intervention critical. Autogenous bone grafting involves using the patient's own bone to fill defects in the furcation area. Techniques such as osseous coagulum and bone blend are commonly used. These grafts promote healing and regeneration of periodontal tissue, improving tooth stability and function. Autogenous grafts are preferred for their biocompatibility and reduced risk of rejection. Allografts, such as freeze-dried bone and demineralized freeze-dried bone, are donor bone materials used to fill furcation defects. Alloplasts, including hydroxyapatite and tricalcium phosphate, are synthetic materials that support bone regeneration. These options are valuable when autogenous grafts are not feasible, and they help restore periodontal health and function in the affected area. Citric acid root conditioning is a technique used to prepare the root surface for regenerative procedures. By applying citric acid and positioning a coronally advanced flap, clinicians can enhance the healing response and promote tissue regeneration. This method is often combined with other regenerative techniques to improve outcomes in Grade 2 furcation involvement. Guided tissue regeneration, GTR, is a technique that uses barrier membranes to direct the growth of new periodontal tissue. By preventing the migration of epithelial cells into the defect, GTR allows bone and connective tissue to regenerate. This method is effective for Grade 2 furcation involvement and can be combined with bone grafts and root conditioning for enhanced results. Combination techniques involve using multiple regenerative methods, such as bone grafts, guided tissue regeneration, and root conditioning, to maximize healing and tissue regeneration in the furcation area. These approaches are tailored to the specific needs of each patient and defect, improving the chances of successful outcomes in Grade 2 furcation involvement. Regenerative procedures have limited success in Grade 3 and 4 furcation involvement due to extensive bone loss and poor access. Early intervention is crucial for achieving favorable outcomes, as advanced lesions are less responsive to regenerative therapy. In these cases, traditional or surgical treatments may be necessary to preserve tooth function and prevent further deterioration. Root resection is performed after appropriate local anesthesia and flap release. The root with advanced bone loss is resected using an oblique or horizontal incision. The root is elevated and removed, and odontoblasty may be performed to correct deformities. If adjacent teeth have bony defects, resective or regenerative procedures are carried out. The flap is then approximated and sutured. Vital resection should use a horizontal incision to minimize exposure of the pulp chamber and reduce postoperative pain. Hemisection involves the surgical removal of a root with its associated crown portion. After anesthesia and flap release, the root is sectioned and removed, and the remaining tooth structure is reshaped as needed. Hemisection is commonly used in lower molars with severe furcation involvement. Proper technique and postoperative care are essential for successful healing and restoration of function. Root separation, also known as bicuspidization, involves sectioning the root complex and maintaining all roots. This procedure is frequently performed in mandibular molars with 2 roots. After sectioning, each root functions as a separate unit, improving access for cleaning and maintenance. Root separation is indicated for cases where preservation of both roots is possible and beneficial. Tunnel preparation involves transforming a grade 2 lesion into a grade 3 or 4 for better access. This procedure is rarely performed today due to the increased risk of root caries. The goal is to create a thorough tunnel, allowing easier cleaning but potentially compromising tooth integrity. Alternative treatments are preferred for most cases. Postoperative care is vital for successful healing after surgical procedures for furcation involvement. Patients should follow instructions for oral hygiene, avoid trauma to the surgical site, and attend follow-up appointments for monitoring. Proper care reduces the risk of complications, promotes healing, and ensures long-term success of the treatment. Long-term maintenance and plaque control are critical for preventing recurrence of furcation involvement. Regular professional cleanings, patient education, and home care routines help maintain periodontal health. Special attention should be given to multi-rooted teeth and furcation areas, which are prone to plaque accumulation and disease progression. Adjunctive therapies, such as antimicrobial agents, local drug delivery, and host modulation, may be used to enhance treatment outcomes for furcation involvement. These therapies target bacterial plaque and inflammation, supporting the healing process and reducing the risk of recurrence. Integrating adjunctive therapies into the treatment plan can improve overall periodontal health. Educating patients about furcation involvement, its risks, and the importance of oral hygiene is essential for successful management. Patients should understand the need for regular dental visits, proper brushing and flossing techniques, and adherence to treatment recommendations. Empowering patients to take an active role in their oral health helps prevent disease progression and ensures long-term success. Complications in furcation management include persistent infection, root caries, tooth mobility, and failure of regenerative procedures. Anatomical challenges, such as difficult access and complex root morphology, can hinder treatment. Addressing these complications requires careful planning, patient cooperation, and ongoing maintenance to achieve optimal outcomes. Advances in regenerative medicine, biomaterials, and minimally invasive techniques are shaping the future of furcation management. Research into new graft materials, growth factors, and improved surgical methods holds promise for better outcomes. Staying updated with current developments ensures that clinicians can offer the best possible care for patients with furcation involvement. In summary, furcation involvement is a complex condition affecting multi-rooted teeth, with significant implications for periodontal health. Early diagnosis, appropriate classification, and tailored treatment strategies are essential for successful management. Traditional, surgical, and regenerative procedures each have their place, depending on the severity and anatomical features. Ongoing maintenance, patient education, and adjunctive therapies support long-term outcomes. By understanding the anatomy, etiology, and treatment options, clinicians can effectively manage furcation involvement and improve patient quality of life. Let's look at a clinical case, example of furcation involvement in a mandibular first molar. The patient presents with a grade 2 lesion, partial bone loss, and mobility. After diagnosis and assessment, treatment includes scaling, root planning, osteoplasty, and regenerative procedures. Post-operative care and maintenance are emphasized, with regular follow-up to monitor healing. This case illustrates the importance of individualized treatment and ongoing care for successful outcomes. Thank you for joining us in this comprehensive exploration of furcation involvement and its management. By understanding the anatomy, classification, clinical features, diagnosis, prognosis, and treatment options, dental professionals can provide effective care for patients with this challenging condition. Remember, early intervention, tailored therapy, and ongoing maintenance are key to preserving periodontal health and tooth function. Stay informed about advances in the field to continually improve patient outcomes.